Current concepts in anorectal sepsis pattern and operative options. Dr. Samrat Jankar bring greeting from Kaizen Gastrocare Pune, Symbiosis University Hospital Research Center Pune. This presentation has been done in 19th AMASICON 2024 Hyderabad. Thanks to organizing committee and Dr. Parthasarthi sir for giving opportunity to present this topic. The topic has not been told fistula or abscess, it told anorectal sepsis. In fact, Dr. Rajna Sukal tell there should not be any perianal abscess or fistula. It should be called as anogenital sepsis. If we do this, we have done the justice for fistula or abscess treatment. I have disclosure that most of the images concepts in this presentation belongs to Dr. Rajna Sukal. I am thankful for Sukal sir for giving this to deliver the talk here. All the talk revolve around these three statements of Dr. Rajna Sukal. Anogenital sepsis are predictable. It's not rocket science. We can predict any anogenital sepsis. It's always spread between the muscles and into the spaces until and unless it is iatrogenic. Anal anatomy and patterns are constant. We have to understand better about the modern anal anatomy. Pathogenesis of anogenital sepsis. Primary anogenital sepsis always travels path of least resistance except when it is due to prior surgical intervention or disease of non-cryptoglandular origin such as TB or Crohn's. So friends, when the disease starts at the dentate, it goes to intersphincteric space. Once disease goes there, internal sphincter goes in spasm and it's become tight. Now the path of least resistance cannot come back to a dentate. It has to find the path of least resistance. Either it goes down between the internal and external sphincter, become a low intersphincteric fistula. If it goes into the muscles above, it become high intersphincteric supralevator abscess or fistula. If it travel between the subcutaneous part of the sphincter muscle bundles or in between the subcutaneous and superficial, it become a low transphincteric fistula. If it travels in between the levator and superficial external sphincter muscle, it become a high transphincteric fistula. Have these natural patterns. What pattern it can form as per the Rajna Sukal sir is low intersphincteric type, travel between the sphincter, low transphincteric, travel between the external sphincter subcutaneous and superficial part. High transphincteric, anteriorly it involves the deep perineum, so anterior high transphincteric. Posterior high transphincteric, it involves the deep posterior space because of that posterior high transphincteric type. If it goes in between the muscle above high intersphincteric or supralevator. Pattern 1 is low intersphincteric type. It can be abscess in between the sphincter or it can be fistulous tract. The sepsis always start at the internal opening at the dentate, travel to intersphincteric space below the level of dentate, extend between the internal anal sphincter and subcutaneous part of external sphincter, reaches to perianal space either in the form of abscess or in the form of fistula. Internal opening only in low intersphincteric type can be located anywhere 1 to 12 o'clock. This is a fistula, MR fistulogram of patient having intersphincteric abscess. We can locate in coronal section. There is an intersphincteric abscess. Radiologist is quite confident that disease is limited medial to the external sphincter and the disease is there in intersphincteric space. So we is a case of low intersphincteric type of fistula. We are not at all concerned of incontinence. Going for sphincter cutting procedure is a better option related with fistulectomy or fistulotomy, whatever suits in your. This patient, what we have done is we have seen the abscess and found out internal opening which has been mentioned on MRI, and we are taking an incision in intersphincteric area and we have taken an incision in intersphincteric area. Then from that we placed the probe, and then we have opened up complete internal sphincter and mucosa. This is PI component, proximal intersphincteric fistulotomy, where we have divided complete internal sphincter and mucosa beyond the dentate and lay opened everything and drained out the abscess and thoroughly debrided and buzzed with the bipolar completely. Even high intersphincteric area we should not leave because disease component remain above the dentate, and buzz it the submucosa and intersphincteric space with bipolar so that leftover disease will be taken care, and we are placing the tube into the cavity so that thorough wash can be given in the post-op for better healing of the wound. Low transphincteric type, the disease start from the internal intersphincteric space and crosses the few bundles of subcutaneous part or in between the superficial and subcutaneous part. It can be abscess or it can be fistula. Sepsis from internal opening crosses between the bundles of subcutaneous external sphincter or between the subcutaneous and superficial external sphincter, enter the perianal space or ischianal space. Internal opening at any direction, but most commonly transphincteric fistula lies anteriorly. This is a patient, female patient, having abscess, hyperintensity seen in the perianum space and ischianal space that is going anterior to the at 11 o'clock, goes into the internal opening at 12 o'clock. So MRI has defined as female, although it is a low transphincteric fistula. Patient is needing sphincter cutting procedure, but considering anterior female patient, anterior fistula in female patient, we need to preserve the sphincter. All low transphincteric fistula type need sphincter cutting procedure, but exception to this is anterior fistula in female, recurrent fistula with low pressure or the squeeze pressure is poor because of prior surgery, known IBD or Crohn's, post radiation, we should consider for sphincter procedures. So we have done intersphincteric dissection and we planned for doing the Piltech, which is a sphincter preserving procedure for this lady, and we have went in the intersphincteric groove, identified on the both the side, hooked it over the mixture, and then planned for going for proximal intersphincteric fistulotomy. Proximal intersphincteric fistulotomy. And we are disconnecting the fistulous tract beyond the dentate and we are buzzing the intersphincteric space with bipolar and then ligating the tract over the external sphincter. By this, we are completely taking care of central component. Then we will go for the lateral component, drain the abscess cavity, wash it, and we can appreciate that this is the cavity we have opened up and completely wash, clean, and put a tube for thorough washing post-operatively. So this is a patient who has underwent prior 3 surgery, 2 for abscess, 1 for fistula, come with multiple external opening. MRI was telling internal opening at 12 o'clock, but we had tried to push and probe. We can't exactly identify, but we know that at 12 o'clock at dentate there is internal opening, and this patient has prior 3 procedure and gone through lot of pain. He is not willing for another one chance again to get the fistula. So this patient we planned for going a fistulectomy, but as per our routine we gone in lift intersphincteric dissection, completely dissection done. We are doing the PI part, that is proximal intersphincteric fistulotomy, that complete fistular tract with internal opening disconnected from the internal sphincter and mucosa and submucosa, so that complete disease component we are taking out, we have taken out. Now we are going for external opening across all 3 to 4 external opening. We have taken care, and we want complete disease to get rid, so that he should have least chance of another one fistula in future. So completely we are excising the disease component. Although the patient has prior 2 times surgery, we want it because patient is literally frustrated with the disease. So we have taken out completely and we removed, and complete disease is out. After that, we can appreciate intersphincteric space. This is the internal sphincter and mucosa. This is the external sphincter component. We can well appreciate, and this is a part of deep perineum space. Now we can leave it, but we are doing the intersphincteric cauterization. We have taken a pre-placed stitches by using PDS 20 to take reconstruction of the sphincter, and knots we usually place outside. We can see that the scope is giving with difficulty, means continence has been achieved. Nicely we have taken care, and we have narrowed down the external cavity. We are taking few stitches to make wound approximation, and patient has completely set on for this patient. And cross diagnosed, we are placed a pre-placed set on, so that the sphincter preserving procedure has been done, although it is a low type. Anterior high transphincteric, the fistula tract start between 11 to 1 o'clock, goes above the superficial part of external sphincter at the into the across the crosses above the level of superficial external, or in between the levator and superficial external sphincter, and usually lies between 11 o'clock to 1 o'clock. We had, and she is having no external opening, but there is internal opening at 12 o'clock, having a cavity and the hyperintense cavity on the left perineum space. This is kind of sinus, but it is pattern 3 anterior high transphincteric. Even she is female, so we need a sphincter preserving. Lady. So a sphincter preserving procedure is the better option for anterior high transphincteric type of. For this lady, we have planned in prone position. The probe has been put, ultrasound probe has been placed, identify the cavity which is there in the perineum. We have taken the incision over the cavity, and we nicely opened up the cavity outside. Then we want to go ahead with a Peltec procedure, intersphincteric dissection done. We went inside and we isolated the track properly on the both the side. We placed the fistula probe, and over the track we just using the mixture hooked up the track nicely in the intersphincteric space. Track has been hooked up, track has been completely hooked up, and then we have done proximal intersphincteric fistulotomy. Proximal intersphincteric fistulotomy has been done, so that we can disconnect the internal opening from the anal canal completely. We can appreciate that how much thick internal sphincter, this internal sphincter spasm was not allowing her to heal properly. She has undergone 2 prior procedures prior to this. We are just buzzing the intersphincteric space submucosa by using bipolar, so that rest over the cryptoglandular component we will take care proper. We are buzzing all the deep intersphincteric space and the submucosal space. We are ligating the fistulous tract over the external sphincter. Tight ligature done using Vicryl 20. Later on, we need to deal with the external component. So we made a patient in prone position. Complete cavity was thoroughly debrided and opened up nicely, and placed the tubes to give a wash of the cavity. Posterior high transphincteric fistula. This fistula start at the internal opening 6 o'clock to 5, 7 o'clock, goes into the deep postanal space. Either on one side is from anal or infralevator abscess. This is pattern 80 to 85% follows like this. In 5 to 10% it goes below the anococcygeal ligament, goes till the level of coccyx and comes up, is mimic a pilonidal sinus. Sometimes the fistula directly, now without going into the deep postanal space, directly come on ischioanal space, presents as a ischioanal or infralevator abscess. So sepsis start from internal opening at posterior midline from 5 o'clock to 7 o'clock, most commonly at 6 o'clock. It involved deep postanal space, infralevator and ischioanal space, and internal opening usually lies between 5 to. This is a patient having a posterior high transphincteric abscess which is extending even into the perineum space, internal opening at 6 o'clock. So type pattern, then we need a sphincter preserving surgery, whatever better in our. So for this patient, we have taken in a prone, we have done intersphincteric dissection, gone intersphincteric dissection, we have done proximal intersphincteric fistulotomy, and after doing proximal intersphincteric fistulotomy, our aim was to buzz out all the cryptoglandular, hooking up the tract we have done, and we have done proximal intersphincteric fistulotomy. After that, from internal opening, we went in the deep postanal space, and deep postanal space was dilated and whole abscess and infected tissue was curated. While doing deep postanal space cleaning, we need to put one finger over the levator, made patient in lithotomy position to drain all the abscess cavity washed off, all the pus has been drained off, and after that we may seen this patient completely healed at the month of 2 month post-op. So this is another one interesting case. The patient who had a internal opening at 6 o'clock, we can appreciate hyperintense fluid which is going in high 6 o'clock and opening, it is a 6 o'clock and open going below the anococcygeal ligament, opening in the level of tip of the coccyx, that is pilonidal. We flushed with hydrogen peroxide. It is one of the early case where I used to do maximum lift, and a patient had a prior 2-time surgery. We have done intersphincteric dissection, and after doing intersphincteric dissection we have ligated the tract, but in lift it is bit difficult to tackle the tract which is deep. So for this patient we have done, after ligation we flushed the internal opening, the hydrogen peroxide is coming in the anal canal, so means we have not ligated the tract or falsely ligated. Again we have hooked up the tract, we divided partly, hooked up the tract, and then we have divided a tract completely. After division of the tract, we can appreciate the hydrogen peroxide only in intersphincteric space, means the proper division has happened. So tract has been ligated on internal external sphincter side. This patient has healed after 3 months. Interesting type of fistula, high intersphincteric type, where sepsis start from internal opening, spread upward in intersphincteric space, that is high intersphincteric space, reaches to supralevator. It can extend into the inguinal, pararectal, perivesical, inguinal, even abdominal cavity, retroperitoneal, pancreas, till the lower thoracic cavity has been seen. Internal opening usually locate posteriorly. So this is a patient of high intersphincteric fistula with abscess, means high intersphincteric pattern. So he is having the abscess only located in intersphincteric space. We can appreciate the external sphincter is ballooning, but the disease component is lying medial to the external sphincter. So this is classical high intersphincteric type where we need intraanal fistulotomy. Intraanal fistulotomy can be done from dentate inside, or we can start at the level of intersphincteric groove, but we prefer starting at the level of intersphincteric groove and completely removing the intersphincteric area till the level of anorectal or below the anorectal ring, internal sphincter mucosa. So we do wide fistulotomy inside the anal canal. So it is an intra-anal fistulotomy. We marsupialize the wound and we thoroughly debride the intersphincteric area, intersphincteric area, and we bust the deep intersphincteric space. We are going intersphincteric space. We can see that at the level of dentate, we can appreciate once we reach beyond the dentate, the pus is coming. So for this, we drained out the pus, and complete after pus draining out, we just drained out complete pus, and after that we have done proximal intra-anal fistulotomy. This is going beyond the dentate, so we can go up to the anorectal ring. Even above also it is circular muscle, not going to cause, but only raw area will be more. Our main intent is 1 centimeter above the dentate level. If we curate everything, chances of recurrence will be less. So supralevator cavity we are just thoroughly drying, and we are having so big cavity, so we place one feeding tube inside the anal canal for post-operative. So this is another one case who had prior fistulotomy but having the high intersphincteric fistulous tract. We started at the level of intersphincteric groove, going and dissecting intersphincteric region, going above and hooking the tract. So intent is complete tract need to get disconnected. So we seen the tract, we are trying to disconnect the tract from both the right and left side, so that tract will be completely disconnected. Our intent is to do the intra-anal fistulotomy. So once tract is completely disconnected, we just curated and thoroughly curettage of the tract has been done. Then we are just taking again incision in extending into the anal canal and buzzing out the whole intersphincteric space, and complete intraanal fistulotomy has been done. Now whatever leftover tract we are dilating nicely and curating the tract. We place the tube inside the cavity for thorough washing, and we are fixing the tube over the external sphincter for intraanally. We have not divided the external sphincter. So posterior high transphincteric plus high intersphincteric. This is a pattern 6, which is the most complex. This is a posterior high transphincteric type, posterior high plus high intersphincteric. So this is need sphincter. This is a case we had abdominal wall sepsis and collection in the left side of the abdominal wall. There was gas under diaphragm, has been mentioned by radiologists. MRI wise we can see that the fistula, which is starting at a 6 o'clock, abscess cavity is going pararectal, prevesical, groin, and left side of the. So patient in a prone position, patient in a lithotomy position, we have seen internal opening at a 6 o'clock position, and then we gone above to take care of the abscess component. We have taken a multiple counter incision over the abdominal wall to drain out the abscess completely. Abscess has been completely started draining all the areas. Thorough draining of abscess cavity was done. And we place one gauze piece by long artery. We can see that gauze is coming from internal opening, and we are debriding by using the gauze complete cavity. We are doing the intra-anal fistulotomy to take care of the component, intraanal component, and we are giving counter incision over the scrotum to debride, and this is a posterior high transphincteric tract opening at the level of coccyx, which has been cleansed and thorough debridement washing done and packing done. 2-3 times we have taken care of this washing cleaning in the OT. Later on we place the feeding tube of 8 French at the 45, and this is the image at the level of 60. Now it is almost 1.5 to 2 year patient is doing absolute. To conclude, low intersphincteric type pattern 1 needs sphincter cutting procedure. P2 low transphincteric, we can do the sphincter cutting procedure. P3 anterior high transphincteric sphincter preserving procedures are better. P4 posterior high transphincteric sphincter preserving procedure are better. P5 high intersphincteric type sphincter cutting, that is intraanal fistulotomy, is better. P6 sphincter preserving procedures are preferred. Thank you.